Okay, I think I can get this done before lunch is over. So, pneumothorax. What is a pneumothorax? Well, a pneumothorax is where you've got some kind of disruption in your lung and air, or from the outside, but basically you've got air in your pleural cavity that's not supposed to be there. There's a little bit of fluid in there. Remember, you got some fluid in your pleural cavity that helps your lung expand during breathing. So you've got some air in there that's not supposed to be there. Air is supposed to be inside your lung, but not outside your lung. So when you get air out there, it actually starts pressing and building up pressure in there and starting to collapse your lung a little bit. So we have what we call a simple pneumothorax and a tension pneumothorax. So a simple pneumothorax, it usually kind of resolves on its own. It's very small. The injury to the lung kind of heals itself over, and so the air is not escaping out there anymore, and it just kind of reabsorbs. Causes of this, causes of a pneumothorax can be like blunt trauma to the chest, a penetrating trauma, medical procedures. So sometimes we'll put in what's called a central line into their subclavian, and it's really easy to accidentally hit their lung, and you can collapse their lung doing that. So that's bad. Sometimes with positive pressure ventilation, you can actually cause a lung to have some damage to it. Air starts leaking into your pleural space, and then you end up with a pneumothorax. And then sometimes it's just spontaneous. Tall, white, skinny smoker guys are at high risk for a spontaneous pneumothorax. Why that particular group of people, we don't know, but that particular tall, skinny, white smokers, guys, males, will actually just for no reason develop a pneumothorax. So if the pneumothorax gets to be a significant size and puts a whole lot of pressure and tension on your lung, it becomes what we call a tension pneumothorax. So with a tension pneumothorax, you've got significant pressure that's built up in your lung now, and you've got to do something about it. Simple pneumothorax, we usually don't treat. We just monitor it, observe it, keep an eye on it, make sure it's not turning into a tension. With a tension pneumothorax, you have to do something immediately to fix it. So normally what we do, emergent treatment for that, is to do what we call a needle decompression. You just take this big old needle, you go in between your second and third intercostal space, mid-clavicular, you stick the needle in there, and whoosh, air comes out. And so it's not a typical nursing procedure. The provider will do that. You get this rush of air out, and it temporarily fixes the issue until you can get a chest tube in. The tension pneumothorax will require a chest tube. If you don't fix a tension pneumothorax, they will actually, you'll go from like decreased breath sounds to now you've got absent breath sounds because this lung is totally collapsed, so you hear nothing on that side, and then your trachea starts to deviate. So your trachea is no longer midline, it's pushed over to one side. I had a doctor tell me one time that you could not see tracheal deviation until the patient was post-mortem, and told the doctor that he better come to the ICU and take a look at this guy because he must be dead because he had tracheal deviation. We had just intubated him like 30 minutes before that, and then he rapidly deteriorated because he developed a tension pneumothorax. So you can see tracheal deviation before they're dead, but those are some of the things that you can be concerned about. It can actually develop so much pressure in your chest that it can compress your heart, and you can actually go into cardiac arrest, PEA. That pulseless electrical activity where your heart's still trying to do something, but there's so much pressure in there that your heart's not able to beat. So those are some of the things that you can see with a tension pneumothorax. If you've got a tension pneumothorax and you're on a ventilator, that's just going to keep making it worse, because every time it's ventilating, it's putting more and more pressure and putting more and more air into your lung, into that pleural cavity, and it's just making your pneumothorax worse. Again, the emergent treatment is a needle decompression, and then we're going to put a chest tube in. A hemothorax is when you've got blood in that pleural cavity, and then a hemopneumo is when you've got blood and air in that pleural cavity. So if you've got a chest tube in, we've talked a little bit about chest tubes, so anytime you have more than 100 mils of drainage from a chest tube in an hour, that would be a reason to contact your provider and let them know, because they should not be draining that much fluid or that much blood out of their pleural cavity. If you see continuous bubbling in your monitor, that means you've got an air leak. So initially when you put your chest tube in, you've got an air leak. That's why you put the chest tube in. There's air in there that's not supposed to be. So you'll see some continuous bubbling, but continuous bubbling does mean that there's an air leak. So if your bubbling had stopped because your lung had re-expanded and your problem had resolved, then yay, life's great. And then all of a sudden you see it start to bubble again. That means your pneumothorax has returned and you've got another air leak. So what are you going to use your unlicensed assistive personnel for when you have a chest tube? Well, there's not a lot you can use them for, but they can go in, every shift we got to go in and mark how much drainage we have, intake, output. That's something that an unassisted licensed person can do. Just like they document I's and O's for you. They, pick up a lunch tray, write down they had 240 mils of a drink, or they dumped a urinal and there was 100 mils of urine in it. They can go and they can mark on your chest tube drainage that they had 100 mils out on your 12-hour shift. They can do that. So other than that, there's not a lot they can do, because if you're pulling specimens for cultures from your chest tube, if you're checking bubbling, if you're checking titling, if you're checking to make sure that your chest tube, that you don't have any dependent loops in your chest tube, things like that. If you're checking for air leaks, those are not things that an unlicensed person can do. So pretty much the only thing they can do with a chest tube is mark for you that you had some drainage in it. So those are pneumothorax, or pneumothoraxes, hemothoraxes, hemopneumos, intention pneumothoraxes. Hope that kind of makes a little bit of sense and explains some of those a little bit better.